Hi, my name is Dr Arani Pillai. I'm a consultant obstetric anaesthetist from Nottingham, and I'd like to tell you about the UKOSS study into peripartum hyponatremia. This was a study born after multiple case reports about this condition, resulting in, amongst other things, maternal and neonatal seizures around labour and birth. We wanted to find out the national incidence, the way this condition was being managed, and also the outcomes for mums and babies. We used UKOSS methodology, which meant that local reporters were collecting cases of this condition in consultant-led obstetric units, UK-wide. And the case definition was symptomatic hyponatremia with a sodium less than 125 millimoles per litre in labour or the 48 hours following birth, where importantly other causes had been excluded. 80 cases were submitted over 18 months. 10 cases were excluded because the sodium was above 125 millimoles per litre. 13 cases were preeclamptic, and this was excluded because this has a separate etiology of hyponatremia and can cause headache and seizure without a low sodium. This left 32 true cases with a low sodium lower than 125 and documented symptoms, but a further 25 where there were no documented symptoms despite the sodium being less than 125. This group was analysed separately because there appeared to be neonatal adverse outcomes amongst them. So the true incidence from this study was 3 per 100,000 births of symptomatic maternal peripartum hyponatremia based on embrace birth rate. These were the maternal symptoms presented amongst our cases. In the cases with documented symptoms, there was a statistically significantly lower median lowest sodium in the mums compared to those without documented symptoms. So 118 versus 121 millimoles per litre. However, this may not have had clinical significance. Most cases that were presented were primiparous at birth. This was both cases with and without documented symptoms. There was a higher than expected proportion of cases that initiated their labour management at home and then were transferred into consultant-led care. And there was a higher than expected number of cases where birthing pools had been used. This is higher than expected for UK practice. There was a lower than expected spontaneous vaginal birth rate, so 38% with documented symptoms and 20% without. Amongst the neonatal characteristics, there was a higher than expected neonatal admission rate, even in cases where there were no maternal symptoms documented. And worryingly, there were cases of neonatal hyponatremic seizures in mums where there were no documented symptoms of hyponatremia. The fluid intake in labour was particularly poorly documented. In cases where there was an oral fluid balance chart, there was not much difference between cases with and without documented symptoms in terms of how much fluid was drunk. However, where there was a retrospective estimation of oral fluid intake, it did appear that there was a significantly high intake in cases where there were documented symptoms. So the median intake was 4 litres in those with documented symptoms compared to 2.7 litres in those without. However, the numbers are pretty small in both groups. In terms of management, most cases spontaneously resolved with only fluid restriction, and very few were given hypertonic saline. There was no morbidity associated with any treatment, and the condition resolved very fast in both cases using hypertonic saline and just fluid restriction. And so, recommendations for clinical practice now as well as for future research. We felt that the incidence that we obtained from this study of symptomatic peripartum hyponatremia was an underestimate. This is based on other studies and case series published within the UK and elsewhere, showing that hyponatremia is actually quite common. We also found that the symptoms and signs of hyponatremia were not well understood amongst both the reporters and amongst the maternal records. To achieve early identification, we felt that there was probably a need for several things. One is that fluid balance is being poorly done, and particularly seeing that low-risk settings were more commonly found within our study. Fluid balance in those settings is probably important. And then targeted electrolyte tests in cases where there is a higher risk. So particularly looking at where birthing pools have been used and home birth transfers may be important. There is also an apparent link to operative birth that needs further evaluation, and perhaps an overall risk stratification tool needs to be created and then tested, which may help. Thank you very much.